Mustang Bio is a company that's focused on cell and gene therapy, and I'm going to discuss two separate aspects of it. First, in terms of the cell therapy, we have an active CAR T program. We have CAR Ts that are directed against a CD20 antigen that's common in lymphoma, and we are focusing on non-Hodgkin's lymphoma, chronic lymphocytic leukemia, Waldenstrom's macroglobulinemia. And in the lymphoma category, we're focusing on both aggressive lymphomas and the indolent follicular lymphomas. We also have CAR Ts against glioblastoma, and we're combining it with an oncolytic virus. And we showed recent data at the AACR on the CAR T. We're very excited about that. In the gene therapy group, we're looking at XGID. XGID is more commonly known as the bubble boy disease. And we have a gene therapy that's being presented at today's ASGCT meeting in Washington, D.C., where we'll be describing the incredible work done by the St. Jude and other collaborators in restoring the immune function to patients with XGID. XGID is the combined immunodeficiency, and again known as bubble boy. You know, Mustang Bio has really three pillars that will lead to our success. One is the people. We're roughly about 120 employees right now, and we're growing very quickly. Our assets, as I mentioned before, are both CAR T, which we have for both the lymphoma, chronic lymphocytic leukemia, as well as a different CAR T for glioblastoma, gene therapy for the bubble boy disease, XGID. So we talked about the people, the assets, but we also have a facility right now. It's located on the University of Massachusetts Medical Center's campus. It's in Worcester, approximately an hour west of Boston. And with the combination of people, assets, and facilities, we will be doing exactly that, advancing 2 assets per year. Currently, we anticipate opening up the CAR T therapy for lymphoma and chronic lymphocytic leukemia in the next few weeks. It's already IRB approved at multiple sites, and we should be enrolling our first patient very soon. The XGID, which is the gene therapy asset for bubble boys, we anticipate enrolling the first boy in August of this year. And then next year we'll have the glioblastoma asset coming online. And again, the glioblastoma asset is a CAR T product given in conjunction with an oncolytic virus. The oncolytic virus makes the cold tumor hot and makes the CAR T much more effective. So how are we going to do it? A combination of people, asset, and facility, and a lot of great collaborators. You know, manufacturing is indeed a challenge. I believe we have the right folks in the company who are able to do it. We are automating as many steps as possible. We're also making closed steps as many as possible. So our model is we support academic investigators who develop the CAR T and gene therapy. And as an example, we have brought in CAR Ts from Fred Hutch Cancer Center in Seattle, Washington. We brought in a CAR T from the City of Hope in California. We have brought in gene therapy from St. Jude's Hospital in Tennessee. And we work very closely with them to mimic the process, the manufacturing process. But what we do is we make it more automated and more closed to develop a product that's more suitable for the commercial environment. First, as a disclaimer, I'm not the manufacturing, I'm the head of clinical development, but I do know the head of manufacturing in our institute, who's Knut Nis, has done this before for multiple companies. It's a process. It can take up to a year to two to get the manufacturing facilities. We have an extremely strong MSAT, Manufacturing Science and Technology group, an extremely strong quality control group, which is looking at each of the steps of the way to ensure that the patient gets a product that's safe, and the quality assurance, which oversees everything to see that the manufacturing process gives the product as specified, and this is closely regulated by the FDA. We have the right winning combination, but it is not an easy task. Yeah, you know, I very much like the question of what can we do to improve the effectiveness of CAR T cells. I just have to say I'm an oncologist since 1986, so 36 years. And so I way predated CAR T cells. And when patients' tumors progressed through the chemotherapy or chemoimmunotherapy, there was nothing for them. And so the CAR T cells have revolutionized the life of the relapsed or refractory lymphoma patients. 50% of them do survive. And that is a wonderful statistic for those who are in that 50%. But as you indicate, the 50% who don't survive, that's a problem. And so the way we are personally addressing it is we're going after a different target. The current CAR T cells that are approved all target the CD19 antigen. Our CAR T targets the CD20 antigen, and the CD20 antigen is a very well validated antigen in the lymphoma field. It's a target for rituximab, which has been around for a very long time. And one important thing about the CD20 antigen is it is not lost. Where in patients treated with CD19 CAR Ts, approximately a third of them will lose their antigen over time. CD20 antigen tends not to be lost by lymphoma patients. So even if patients progress through their CD19 directed therapies, they would still be candidates for our CD20 directed therapies. And we have already announced at the recent meetings, lymphoma meetings, that we have treated patients with CD19, patients who had received CD19 targeted CAR T therapies who then relapsed. They were treated with our product, the CD20 CAR T, and they are now enjoying very much their remission. And I should mention our product, for the most part, is an outpatient therapy. We've had no grade 3 or 4 neurotoxicity, and in the follicular lymphoma, we have not even seen grade 3 or 4 cytokine release syndrome. Almost all the toxicity we see is grade 1 or 2, so it's an outpatient therapy. And the data is very limited, but so far looks like we can take patients who receive CD19 CAR Ts, either for follicular lymphoma or for aggressive lymphoma, and treat them with our product. So CD20 CAR Ts, our product is called MB106, is one way of addressing how to make the CAR T failures. And we're excited about the product because it's taking a validated antigen, CD20, with a validated therapy, CAR T, and just putting the two together. I am so incredibly excited about the oral presentation by Evelina Mamkars of St. Jude's on gene therapy for X-linked severe combined immune deficiency, or XGID disease, which we commonly refer to as bubble boy. I mean, what the oral presentation is showing is data on 23 infants with XGID. And I just have to really emphasize that these patients, were it not for the gene therapy, would be receiving a bone marrow transplant. And bone marrow transplants are not a benign therapy. It's the best therapy we have right now, and it's the standard of care therapy, but it's problematic. With X gene therapy, these are one and done therapies. One treatment for the lifetime therapy. And that's very important. Dr. Mamkars showed 18 patients with greater than 6 months of follow-up. 17 of the 18 have had robust immune reconstitution. And both by laboratory, but even by clinical parameters. By laboratory, we see these children, they're not even babies any longer, but these children, because some of them are out 5.5 years. The median follow-up is 2.5 years, but some are out 5.5 years, have restoration of their T cells, both their CD3 positive T cells and their CD4 positive T cells. The T cell maturity is being assessed by TREX, which are T cell receptor excision circles, and the diversity is assessed by T cell receptor V beta diversity, and you can really see just nice maturation of T cells. But the most important thing is clinically these patients are doing well. They've recovered from pre-existing infections, they're off of protective isolation, and they have normal growth velocity. And, you know, I've spoken to the parents. We meet occasionally with the parents of these children, and they have their children back. And I can't emphasize how important it is. The gene therapy is also shown to be safe. Currently, there's some transient low blood counts that they develop because they receive busulfan conditioning. There's no evidence of malignancy at a median follow-up of 2.6 years. That's an important thing we look at for gene therapy. We will be following these children for 15 years. That's an FDA requirement. So again, this is a one and done gene therapy that's basically been effective in all the patients treated. You know, some of them are going to school now and old enough to go to school and have their normal life back. It's hard for me to overemphasize how this has significantly changed the life of the bubble boy patient.